I don't see you, but I can hear you.
Okay. I'd like to welcome you. I'd like to welcome you to this CME session of the Society of Uganda Gastrointestinal and Endoscopic Surgeons. This is our second CME this year, and this year we are very deliberate about liver transplant. We have the ambition of having a liver transplant done in Uganda by Ugandans within the next 2 years. In preparation for that, we are doing a series of lectures to educate us more about liver diseases and the procedures and processes of liver transplant. So today, we are honored and privileged to have two great speakers who are going to take us through several topics regarding liver transplant. First on the block will be Dr. Saul Kaggwa, who is an eminent member of the Society of Uganda Gastrointestinal and Endoscopic Surgeons. In fact, he's a founder member and is currently the vice president. He is a gastrointestinal and hepatobiliary surgeon based out of Mulago National Referral Hospital, and indeed we are privileged to have him. Dr. Saul, you're welcome to take us through the processes of liver transplant, how to evaluate a donor and the recipient. You're welcome.
Thank you very much, Dr. Emmanuel Alobu. My name is Dr. Kaggwa Saul, as I've been already introduced. I hope everyone can hear me. So I'll be going through the steps or the protocol for evaluating donors and recipients of liver transplant. So we need to know how long has liver transplant been with us. So to know some history about liver transplant, the first successful liver transplant was done by a doctor, a surgeon called Thomas L. Stiles, who is considered to be the father of modern day liver transplant. And this was in 1967 at the University of Colorado Health Center. And then another person to note, when Dr. Thomas did the transplant, the knowledge of immunosuppression was not widely understood. And so the organ transplant, his liver transplant, did not include use of immunotherapy. And so the first person to do liver transplant, in closely similar to the modern day how it's done, was Sir Roy York, from a professor of surgery from Cambridge University Hospital. And this was in 1968. And he managed the patient using cyclosporine postoperatively. And then, as you are aware, we have the dead donor and the living donor. So the first person to perform a living donor liver transplant was Dr. Christopher. And Christoph did the surgery in 1989 when he transplanted part of the liver from the mother to a daughter. And gradually, living donor liver transplant became understood and known to the extent that now, worldwide, depending on the regions, worldwide, 30% of all liver transplants are by living donor transplant. However, we note that in some regions, especially in Asia, majority of liver transplant Asia and I think Arab world, especially Egypt, majority is of liver transplant is through living donors. When we look about the history of organ transplant, then we ask the question, where are we as Africa? What have we been known for? And at least by 1967, we see that the first heart transplant, the first successful heart transplant, took place in Cape Town in South Africa by Dr. Christian Barnard. A lot is written about it because it was a lot of success, especially in the media. And then also, not to be funny, but the first successful penis transplant was also done in South Africa in 2014. So we need to make this shows us that organ transplant and specifically liver transplant is now a common surgery elsewhere. And for the fact that we haven't yet done one here, calls upon us to put in more emphasis, more effort, to be more proactive, to make sure that liver transplant can be done in Uganda as soon as possible, as soon as this year, or as soon as possible early next year. So when evaluating patients or for liver transplant, before you engage anyone, any possible donors, or before you start procuring for the liver transplant, we must make sure that actually liver transplant is the most appropriate treatment. And so this calls us to know clearly the indications, the different indications for the liver transplant in the patients to be considered. But because this part was already dealt with by my colleague, Dr. Okello Michael, in the last CME, you will allow me to move to the next slide. But those are some of the indications, including hepatocellular carcinoma and end-stage liver disease and other less frequent conditions. So this was considered already end-stage liver disease as an indication for liver transplant. And specifically, we looked at patients with a MELD score above 15, who are all other factors are acceptable for liver transplant. However, definitely we have exceptions, and the exceptions to the MELD score, as we shall look in details, we shall look briefly about the MELD score and details later. So let us go on with the presentation. So we have exceptions to that score. Patients may have otherwise a much lower score, but have refractory ascites, have uncontrollable GI bleeding, have repeated encephalopathy, or have portal pulmonary hypertension, and the hepatocellular carcinoma, among others. So there can be exceptions to the MELD score depending on the indications for the liver transplant. So to talk briefly about the hepatocellular carcinoma and the MELD score, here we have to modify it a bit because sometimes patients may have a much lower score but have an aggressive disease and therefore need to be considered as early as possible. So the MELD score here would be used in conjunction with the Milan criteria which classifies liver transplants in patients with hepatocellular carcinoma more clearly. This also was discussed, so that's why I'm not dwelling much about it. Also to consider are the alpha fetoproteins. Patients with high levels of alpha fetoproteins, we know that they are considered to be having a more aggressive tumor, and also considered to have micrometastasis that may predict a poor outcome after transplant. So when you have this patient, you also must clearly look out for any contraindications for the liver transplant, because it's an extensive surgery. It's a very expensive surgery in terms of morbidity to the recipient, but also in cases of living donors, it also carries a lot of morbidity. So you must be sure that there are no any contraindications to the transplant before the transplant goes on. And these are some of the contraindications to liver transplant. And also this part was dealt with by Dr. Kello. So allow me to just go to the next. So when is liver transplant appropriate? The timing, when is it appropriate? So it should be considered in any patient with a liver disease where the procedure of liver transplant would extend life expectancy beyond what the natural history of the underlying disease would predict, or in whom the quality of life would significantly be improved by the liver transplant. So patients should be selected if the estimated survival rate in the absence of liver transplant is more than a year. It's not a surgery you want to do for where the life expectation is expected to be less than a year. And also where the patient has an acceptable quality of life, and the team of doctors think that the liver transplant would be able to improve this patient in the quality of life they live after transplant. So basically, for you to arrive at that decision, the team, multidisciplinary team, need to balance the risk of surgery and immunosuppressive treatment of associated with liver transplant, vis-a-vis the quality of life, the life expectancy this person would live without liver transplant. So when considering liver transplant, there are many assessment models. There are many scoring models, but the commonly used one is the MELD score, which is the model for end-stage liver disease. And this score is an algorithm which is based on objectives of the values of creatinine, bilirubin, INR, and to be able to estimate the prognosis after liver transplant. Initially, it was used in the patients undergoing TIPSI, but gradually it was found to be accurate in predicting liver-related deaths, and that's how it got to be used in liver transplant. So patients with a MELD score of less than 14 or equal to 14 usually have a predictable mortality rate following transplant, which is higher than that of the same patients who have undergone other treatment modalities without liver transplant. And so because of that, generally speaking, patients with a MELD score of more than more than 15 are considered as valid indication for liver transplant in those patients with end-stage liver disease. Definitely, as we saw above, in patients with hepatocellular carcinoma and other conditions, there are some exceptions to the MELD score. So how do you use those? That's how you use them. So they are already constant numbers of that you use to calculate that score, and the value is indicated for the patient. That's the table, Cartas of Medscape. You can look at it and get to learn more details about it. So after confirming the score of this patient, you need to summarize your need or your indications for the patient to present to the panel, the transplant panel or team. To present to the team so that you agree that the best treatment for that patient is liver transplant. And so on that first sheet, there should be a clear indication for the liver transplant. There should be a score, and which is usually between 15 to 30, because we know that if the score is above 30, the outcome is more is less efficient. The treatment is less efficient. The outcome is likely to deteriorate as the score increases, and also indicate any exceptions to the score if present. It's important to indicate any other relative contraindications, such as the age. Previously, we stated that transplant is usually considered in patients who are below 70, but definitely this is not an absolute rule. So any exceptions or relative contraindications need to be stated on that sheet, including the age and the BMI of the patient, because it is understood that patients who are obese or with a BMI of 30 and above have a less preferable outcome. So after that, the evaluation also considers a complete laboratory workup and imaging, and some of the laboratory workup or tests to diagnose any possible undetected problems or diseases, and also help in optimizing the patient for the surgery. We note that these are usually very sick patients, and so there needs to be critical concern to make sure that they are optimized to undergo this extensive surgery. So these are some of the workups done. The PT, the INR, the clotting factors, and thrombins, to make sure that this patient is clearly prepared for the surgery. As we know that liver disease occurs with a number of other organ complications, so it's important to have a complete evaluation to also detect any other problems or organ compromise in function that might not have been detected early. So that's why you need to have the renal function. You have to have a complete liver profile. You need to do an extended electrolyte profile. You need to do a complete lipid profile and all the tumor markers. We know that it's possible to find that this patient may have other diseases, including cancers, and yet the presence of other cancers other than cancer of the liver would be part of contraindications to liver transplant. So this is a workup. We know that these patients after surgery, they are going to be on immunotherapy. So we need to be sure that they don't have any other undetected viruses or any other infections that following immune suppression may be a problem to the patient. So the imaging is both in some instances to have evidence of diagnosis of the disease, including hepatocellular carcinoma, but also to help in planning the surgery in terms of the anatomy of the hepatobiliary system. So that's why we have an abdominal ultrasound scan, a Doppler one, to ascertain, to look out for all the portal system, understand the portal pressures, understand the diameters of the vessels, because these will determine the ease of doing anastomosis of these vessels during transplant. CT angiographies for the same, to map out, to have a detailed map of the portal venous system in planning for the surgery. The carotid Dopplers, we know that with advancing age, we may have atherosclerosis, we may have other factors that compromise cardiovascular systems. And so we need to understand these situations early enough. Patients whose indications for liver transplant is the cancer, such as hepatocellular cancer, we need to have a complete staging CT scan or screening scan to be sure that we don't have metastasis in any other organs apart from disease within the liver. This screening for metastasis, depending on the center, preferably is done in addition to is also potentiated by the PET scan to be able to detect other distant micro spreads. But we know that this is not the standard in all centers. And so CT scan is still listed as the standard of metastatic workup. So liver transplant is a multidisciplinary care. And so we need to have a team that involves all other specialties and have consultations to look out for any situation that may compromise the outcome of the surgery. So we need to have consultations with the pulmonologists. We need to have consultations with the cardiologists. We need to have consultations with a psychiatrist, because this is a highly demanding treatment that will involve regular follow-up and institution of instituting different treatment regimens. And so we need to be sure that the patient is in a mental state that will allow them to go through all these difficult treatment protocols. The ENT, we also need to have an assessment. The gastroenterologist need to assess as a routine, the upper GI endoscopy as a routine, and also colonoscopy in patients with a positive fecal occult blood. Consultation with the anesthesiologists need to be done early to detect any possible risks to the surgery and allow the preparation to start early to have the surgery. So as we said, evaluation of recipient is done first, and then when we confirm that the most appropriate treatment is liver transplant, then we go on to look out for possible donors. As we say, the possible donors, we may consider a dead donor transplant or a living donor transplant. But we need to understand that while in Europe and Western countries, US, the dead donors are the most common. In Asia, we know that most commonly the living donors are more common. And this is because to have a clear list of people waiting for the donation, waiting for a liver transplant, and also to have those available organs appropriated to the most in need is such a big problem in many countries. And so mainly Europe and US, where there is a clear waiting list and better coordination of liver transplant services. In many other countries, using living donors gives the best alternative. Also, we know that the possibility, the availability of living donors has made the liver transplant to be more scalable, to be able to meet as many people as those who need it than what would be available from dead donors. And so globally, living donors constitute now about ranging between 10 to 20% in Europe, but we know that it's the majority in Asian countries. We also know that although many living donors are relatives, there is an increasing rate of having totally unrelated donors, willing donors. So the laws of living donor organ donations and transplant vary from country to country, and at least we know that it specifies preferably for the donor to be a relative. Regardless of who the donor is, the donor should be assured of safety of the procedure and the interest of the donor taken with utmost care. We should be sure that there is no coercion at all, and there is no any enticement such as money. And we should put avenues or provisions for the donors to be able to withdraw from the program without any notification of the recipient or the family, and without making it publicly known to anyone that the donor objected to the program. So we need to have a full history in evaluation of the donor to be sure that the donor follows within the accepted laws. For example, in many countries, even if it's a relative, if he has been staying out of the country, is not considered as a donor who is a relative. So we need to have clear history to be sure that is the appropriate donor. That constitutes phase one. and then to have the basic laboratory workup in phase 1, which is basically the virology, the hepatitis, and also to know the organ function to be sure. Then in phase 2, we go more, a bit more invasive to look into the possibility of having undetectable cancers. So we do the tumor markers, and also we continue with consultations with disciplinary consultations, taking also not overlooking the use of the psychiatrists or psychologists to make sure that the donor is in the best mental state to undergo through the process of surgery for donation. Then after you go through phase 2, then you go to phase 3, which is now more invasive and more specific procedures that now are determined to know the specific anatomy of the donor's liver in kind of preparation, provide a mapping for the future donation. So under this, we have the CT angiogram, the plain CT. One of the issues of the donor should have less levels of steatosis. And so a plain CT is usually done to do the hepatic attenuation index, which is a comparison between the spleen and the liver to see if there isn't much fat in the liver that would make the outcome poor. And those are some of the things that are done to specifically map out the vasculature of the liver in anticipation for the organ harvesting, and also map out the anatomy of the biliary system, that's on image B, in preparation for the transplant. So basically that's what summarizes. That slide summarizes the figure above. And so when evaluating, we use a combination of both MRI and CT scan because they two have limitations and advantages over the other, as we shall see in the future. And we need to be able to use both. Just to note that the CT is would be more appropriate in determining the liver attenuation index. But when we come to the biliary system, the MRI is much better. So that's to show you basically that having a clear images helps to plan the surgery. And that's the end of my presentation. The presentation is basically aimed at encouraging us to be interested in liver transplant, encouraging us to take on further training in hepatobiliary diseases and be ready to do liver transplant, and also to gear our morale for the transplant, which we hope will be done in the near future. Thank you very much. Thank you, sir.
Thank you so much, Dr. Saul, for that enlightening presentation. We now have an idea of who may qualify for to receive a liver, who may qualify to donate. We shall keep the questions to this session to the end of the session, and we shall take all the questions at once. How do I move this? So next is a presentation from our colleagues from Cairo in Egypt. I'd like to note that as SUGES, we are getting into partnership with several institutions and individual surgeons from different parts of the world who will hold our hands through the process of developing our liver transplant program. So it is my pleasure to invite Dr. Sami to introduce himself and thereafter engage into the presentation on liver transplant in the pediatric population. Like they say, the pediatric population, the babies are not small, not just small adults. They have their unique complexities and considerations that we must take into account. So at this point, Dr. Sami, you're welcome to present.
Thank you very much. I just want to make sure that everybody hear me. The voice is okay?
Yeah, we can hear you.
Okay. Thank you very much for this second webinar with my dear Professor Okello and the Ugandan Society for Endoscopic and Gastrointestinal Surgeon. Today's topic maybe it's somehow complexity, but I will try to make it simple as much as I can. Sorry for any interruption because I am in the OR now, so I'm sorry for any interruption or any voices that is high around me. Okay. Okay. Let's start. Okay. Today's lecture is about the uniqueness and the complexity of pediatric liver transplantation. My name is Mohammed Sami Abdelwahid. I'm a hepatobiliary and liver transplantation surgeon in Egypt. I work in this field for 15 years till now. I have traveled to Japan for 1 year and stayed with one of the eminent professor in pediatric liver transplantation, Professor Mori Kasahara, in the maybe one of the greatest center around the world for the pediatric liver transplantation, with a very high rate, about 80 cases per year. Nowadays, in 15 years, they have done about 830 cases till now. So try to just make some differences between the adult liver living donor liver transplantation and the pediatric living donor liver transplantation, because the pediatric population, as you have said just now, have some special consideration and have some differences between the adult living donor liver transplant. So I try to emphasize it as in a simple way, maybe as much as I can. Okay, so let's start. Please, the next slide. Okay, the first maybe differences we see different from the adult is the indications for transplantation in the pediatric population. Somehow there's a lot of differences in this issue. We will start to say in the next slide, please. Unlike the adult transplantation, maybe our main indication in the adult transplantation is the end-stage liver disease due to mostly viral hepatitis or autoimmune diseases, or nowadays NASH, sometimes liver tumor like the HCC. But in the pediatric population, we will see here that maybe the first and the most common indication is the biliary atresia. This causes about maybe 2/3 of the possible indication for pediatric liver transplantation, because of this, the nature of this disease, that this disease maybe is seen maybe in every one birth in every 7,000 births. So mostly, if you have maybe about 1 million births per year, you have mostly about 100 cases maybe of biliary atresia every year. So this is prevalent disease. You will see it very much, especially in the Asian group. I don't know in the African group how this is prevalent, but also in Egypt we have a lot of cases of biliary atresia. Second point here we will discuss is the metabolic liver diseases, and this is something unique you will find in the pediatric liver transplantation, because they have maybe these diseases, inherited diseases or uninherited diseases, but this second point here, the metabolic liver diseases, and metabolic liver diseases also you can see in the pediatric population very common, because they have some inherited diseases with of some enzymes or deficiency in some enzymes. So this will revealed by this inherited diseases or metabolic diseases. Also, we have the one of the main identities in the children in the pediatric liver transplantation group is the acute liver failure. It accounts maybe about 10% of cases worldwide for the pediatric liver transplantation. This is very, very important identity. Most people do not realize it, but this is very important in the pediatric age group. You will not find the same proportion in the adult group. Also, the malignancies in the children, you have the hepatoblastoma. This is accounts for 2/3 of the malignancies in the pediatric age group. Hepatoblastoma is very common, mostly in Egypt. For example, we have about maybe 100 cases per year, and in these 100 cases per year, mostly we have about 25% needs to be transplanted. Okay, so this is also very important. And we also, the last thing, we will talk about some vascular diseases and some cryptogenic liver cirrhosis with unknown etiology. Okay, so we can see here that we have different scope of indications from the adult age group. Okay, so next slide, please. This is maybe my series. I have done 20 cases after I came from Japan to Egypt, and this is all the indications that I was seeing here in my. And this is my series and my patients. Okay, just to remind you, is the same issues. Wilson disease, the autoimmune, the PFIC, Crigler-Najjar, congenital hepatic fibrosis, cytosinemia, for example, and atresia post-Kasai operation. This is maybe the 20 cases I have done. Okay, next slide, please. Okay, this is just two photos I have borrowed from Professor Kasahara about the different morphological and structure of the liver in the different types of diseases or indications for the pediatric age group. You can see this picture and also the other picture after this. You can see in the pediatria there are some difference between the liver morphology according to the disease, the degree of the cirrhosis and the degree of congestion, and maybe sometimes in the metabolic disease you see the liver is very normal, looks very normal, but enlarged somehow. So the shape and the structure and the morphology, this is just to take your eyes to see some different liver morphology. So you can see this one and the other one, and I will not comment again. So you can go for the next one also, and then skip it for the second point. This is also some pictures for different metabolic diseases, okay, in the children. Okay, next one. Okay, one of the main concerns in the pediatric age group is the graft selection and modulation, because now here unlike the adult group, we can have some problem in the small for size issue, but in the pediatric age group we can have the contrary, is large for size. Large for size, this means that the GRWR, the graft recipient weight ratio, is more than 4%. So, okay, go for the next slide and we'll try to explain it very, very simple way, maybe. Okay, this is also some techniques which is evaluated by the Japanese people. They see something, they say this, the puffy fish and the flat fish. Okay, when the liver is mostly in the children, we use the left lateral segment, the LLS. This is maybe the most common used graft in the pediatric age group. And here, just to see if they want to reduce the volume of this liver, or you want to reduce the thickness also of the liver. So sometimes you want to reduce the volume only to cope with the recipient child, that you can prevent the large for size syndrome. And sometimes you because of the abdominal cavity is not so big, and to make a closure for the abdominal cavity and avoid the what's so-called compartmental syndrome, and this will make a very hazardous for the graft. So sometimes you need to also reduce the thickness of the graft. So at that time, this is just buff fish and the flat fish to differentiate when you will use it, and also emphasize it maybe in the more next slides. Okay, next one, please. Okay, when you see here, you have in the preoperative evaluation, we have to see to measure the anteroposterior diameter of the donor graft and the anteroposterior diameter of the abdominal wall cavity of the recipient, of the child. Then you can see if this graft needs some reduction in the volume or in the thickness, that you can close the abdomen without any problem. Because sometimes if you put a very large size graft, you cannot close the abdomen, and you want some mesh to close the abdomen, or you make it not complete closure, and this will go for some infections and very hazardous for the child. So you have to just make this measurement just to see the ratio of thickness, and if you want to make some reduction in the volume or in the thickness. Okay, so next slide, please. Okay, as you see here, these small babies, you have to prevent this picture to happen, that you in these cases you cannot close the abdomen. As you see, the liver is so large and is so big, and you cannot close the abdomen freely. Okay, so in this situation, this is very important, because this is very critical, and this patient mostly had a very bad morbidity and maybe go to mortality also, because of this issue, that the liver is exposed or it is covered by a mesh. So the rate of infection is very, very high in a patient who will take immunosuppression. So at the time, it is very important that we prevent this. Okay, so large of size syndrome, we have to prevent it in the children. This is unlike or something unique you will not find in the adult age group. Okay, so next slide, please. Okay, this is algorithm was proposed by Professor Sakamoto from Japan to deal with this issue in the children below 5 kilograms. Okay, or you have to see what you can do. So, if you have a GRWR, the graft recipient weight ratio more than 4, or the ratio of thickness is more than 1, so you have to go to see if the ratio of thickness is less than 1. Just you have to make what is called the hyper-reduced graft. I will explain it after this. And if the ratio of thickness is more than 1, between the anteroposterior diameter of the graft and the anteroposterior diameter of the anterior abdominal wall of the recipient, this is the ratio. If it is more than 1, you have to make some reduction in the thickness. Okay, but if the WR is less than 4% and the ratio of thickness is less than 1, so in this time you can go safely for the left lateral segment, very classic way, and no problem at this at all. Okay, next slide. This is the types of reduced grafts. Okay, you have two types of reduced graft. One is called the non-anatomical reduced graft, and the other is called anatomical reduced graft. So if you go for the non-anatomical reduced left lateral segment, you can go to a hyper-reduced graft. That hyper-reduced graft, you have to take a part from the lateral edge from the liver to remove from the segment 2 and 3, the lateral edge of segment 2 and 3, you have to get it out. And you get also a part from segment 3, the anterior part of segment 3. So you have a lateral reduction and the anterior reduction. This is called the hyper-reduced graft. Okay. The other side is called the monosegmentectomy. It depends on that you make segment 2 only. You have to remove segment 3 totally, and you have to depend on segment 2 only, with also some reduction in segment 2. You get a lateral reduction for segment 2 and 3, and then you remove segment 3, sorry, and depend on the pedicle to be just with segment 3 only. Segment 2 only, you bend on it. The other type now is used by Professor Kasara, and I think this is modification, that he has a modified S2 graft, segment 2 graft, that in this modified segment 2 graft, he did not remove he followed the Gleagsonian capsule, and he preserved the G3, the Gleagsonian capsule of segment 3, but remove most of the tissue of segment 3. But he this way prevent the injury for the left hepatic vein. Okay, so you can keep the vascular Gleagsonian capsules for segment 2 and 3, but you reduce the parenchyma as much as you can from the parenchyma of segment 3. Okay, so this is called modified S2 graft. This is the 3 types of reduced grafts in the children below than 5 kilograms. Okay, so next slide, please. Okay, now after we have known the indication and the graft selection and the modulation, though, we go also for another very, very important identity in the children in the pediatric liver transplantation is called the portal vein flow modulation. Because this graft is somehow small in all the time, it is somehow small graft, so you have to ensure two things. You have to ensure adequate portal pressure, flow and portal pressure in this graft, because if you have a very high pressure, it is very injurious for the graft, and if you have low pressure, this graft will not be functioning well. So you have to ensure the adequate portal vein pressure and flow in this small graft. Okay. So in the children, we will see now what we can do for this portal vein modulation. Okay, next slide, please. Okay, as you see, the most of pediatric recipients have attenuated portal vein, and this attenuated portal vein, the problem that this attenuated portal vein, if you make anastomosis for attenuated portal vein, this will be accompanied by high morbidity and high mortality due to portal vein thrombosis. So at that time, you have to deal with this portal vein. So one of the issues is the anastomosis for the portal vein. We have 4 types of anastomosis. We have the confluence portal vein, that you make the anastomosis on the confluence of the portal vein, or you have what's called branch patch technique, that you can make it on the right and left branches, but you can make it like wide, make it like a wide opening. And also the other type is the venous graft patch. Sometimes when the portal vein is somehow small or attenuated, you can make a slit in this portal vein, and you can get a venous graft to increase the circumference of this portal vein. And the last thing is the interposition graft. In the attenuated portal vein or sclerotic portal vein less than 3 millimeter, in that time it is mandatory that you get this portal vein out. You cut it from the confluence with the mesenteric and splenic vein, and then you make interposition graft with a natural graft, mostly the left jugular vein from the recipient, of course. So this is very important in the anastomosis portal vein, that you have to ensure the adequate blood flow, adequate portal flow, because portal vein thrombosis and portal complication, maybe it is the highest incidence on the pediatric liver transplantation. It is highest complication regarding the anastomosis in the pediatric liver transplant. Okay, so go for the next slide, please. Okay, this is a novel technique was proposed by Professor Sakamoto, also from the NCCHD, the place I was there, that what we can do for this portal vein, we have to increase the portal vein flow as much as we can, because we have sclerotic or attenuated portal veins in the children. So at this time, they propose what's called the cruise technique. This cruise technique, it depends that you make interruption for the collaterals to increase the blood flow in the portal vein and prevent what's called the steal phenomenon, that the blood is not going out from the portal vein. Okay, and this because if your blood flow is very low, you are supposed that you have a portal vein thrombosis. Okay, so you can have the portal vein thrombosis very easily. So at that time, Professor Sakamoto proposed this cruise technique, that he starts with the main collaterals we have in these children. Mostly we have the left gastric vein and what's called splenic shunt. This is maybe mostly you will find both of them in those children, with portal hypertension. So you have to ligate this, or make interruption to that. You ligate these two big shunts to increase the portal flow. And then the second point, that you try to interrupt all the other collaterals by the diathermy only, that you start from the retrosplenic area. This is retroperitoneal collateral. Start from the retrosplenic area and go for the left paracolic gutter, and then you can go for the right paracolic gutter, and then you can go for the central part around the portal vein. In this cruise technique, you try to interrupt all the collaterals, the small collaterals you see, with the diathermy, trying to interrupt all the collaterals, trying to improve or augment the portal vein flow as much as you can. Okay, next slide. Okay, also this is one of the done by Professor Sahara, which is called pull-out technique. This is used. I myself used it here in Egypt, maybe for 5 cases or something. When you have a portal vein obstruction or portal vein thrombosis, so the portal vein at that time you want to make a thrombectomy, and this portal vein, small veins, it is hard, but it's very difficult that you can do this technique. So at that time, he's supposed to make what's called the pull-out technique. At that time, you have to encircle the supramesenteric vein, the inferior mesenteric vein, and the splenic vein, the three tributaries that who can form the portal vein, and then you dissect, make a small dissection for the portal vein from the retropancreatic part, and you can get this portal vein in front of you. You get it from under the pancreas, okay, in front of you, and then you can deal with this portal vein. At that time, you have two things to do. Either you have to do a thrombectomy in extensive thrombus that is reaching to the portal vein, maybe to the supramesenteric vein or spring vein. You have to make this a very adequate thrombectomy. Or at that time, if the portal vein is very attenuated or very sclerotic or very diseased wall, so you have to remove the portal vein completely and make an interposition graft. And then after you make this graft with the natural graft, maybe from the ovarian vein or the inferior mesenteric vein from the donor side, and you put it again from the retropancreatic tunnel and get the portal vein in its anatomical way. So you just get the pull out the portal vein from under pancreas, and then after you manage what you do with thrombectomy or interposition graft, you put it again from the under the pancreas and continue your work. Okay, this is called the pull out technique. So some techniques to augment and prevent the portal vein thrombose. Okay, next please. Okay, this identity that I have seen mainly in the children, small children, was called the ABO incompatible liver donor destination. I didn't before, and honestly, before I go to Japan, I didn't see this in Egypt at all. I just heard maybe about once or something, but it is not found in my country. But when I go there, I found that they practice this ABO incompatible blood transfusion, because the problem here there that the donors is either it is a related donor or a cadaveric donor. There is no unrelated donor in Japan by the law. So it is only related. So if you have the father and mother, for example, are not suitable donors, so mostly you will have no donors, so you can go to they put the patient on the cadaveric list. So at that time they start to think about this ABO incompatible donor liver transplant. So they have put a regimen, and this regimen also may be practiced in the USA and practiced in the Korea also, and in some countries, maybe France also. So this ABO incompatible blood transfusion can solve the problem of the donors, but it have some precautions and it have some standards that you have to follow. Okay, so we will try to explain it in the next slide. Okay, please. Okay, this is the current immunosuppression protocol for the ABO incompatibility liver transplant. So if you have a patient that is below 1.5 years, in that time, so you don't do anything strange. You go in your way as much as you can. The same immunosuppressive protocol for the other pediatric age group. No difference at all. But if you have a patient that is more than 1.5 years, so you have to give to make 3 modifications at that time. First one is that you have to make rituximab. This is taken 28 days before the operation, about 1 month before the operation. He give only one dose of rituximab. And then before the operation, you do a plasma exchange, what's called electrophoresis, maybe for 4 sessions before the operation. And then you start the MMF, mycophenolate 10 milligram per kilogram per day, 1 week before operation. So this is the differences you do in the ABO incompatibility if the child is more than 1.5 years. Okay, so next slide, please. Okay, this is the long-term outcome for the pediatric ABO incompatibility by Professor Kasara. You will find a small difference between the normal way, which is the compatible ABO, and the incompatible ABO, especially in the children below 1.5 years. Mostly this regimen is reserved for the children below 1.5 years because there was no agreed change in the way you are going to deal with the patient after the operation. So the post-operative period will be the same. So mostly this is reserved for the young babies. Okay, so next please. And this is the current strategy now that they make a daily evaluation for the anti-A and anti-B titr every day for 14 days, and they use the rituximab once before the as I said, one dose 1 month before operation, and they give the tacrolimus and MMF before the transplantation. MMF is 1 week before transplant, and avoid portal vein and hepatic vein therapy, and avoid of splenectomy. As I told, maybe I said few minutes ago, I insist about the acute liver failure in the children, because this is very, very important identity, because it costs about 10% of the cases. I mean, if you have an 100 case per year, so you have 10 cases per year, okay? So this is a very, very important identity in the children. Some people does not realize it. And you will find the rate of the acute liver failure in children is very, very high, much, much higher than the adult group, okay? So you'll find it mostly in the children. So this is very important to put in mind. And if you want to promote your center, that you have to make a lot of what is called a lot of instruments and a lot of tools that you use in these cases, because these cases is very important to save. After you save this patient is will go in a very good track. I myself attended in Japan 9 cases in the year I was there. I attended 9 cases of acute liver failure, and all of them go straight forward after the operation, and all of them was discharged in a good health. So you have saved a life. Okay, so this is very, very important. So next slide, please. Okay, the etiologies outcomes, as I told you, is varied by the age as well as the regional exposure and resources. The treatment is generally supportive unless the diagnosis is done for the acute liver failure. And liver transplantation is maybe the only life-saving condition for this patient. Okay, so please, next one. Next slide. Okay, this is definition by the acute liver failure. As you see, you can see the liver in different condition, mostly the Wilson disease and the mitochondrial hepatopathy and this issue, and hemochromatosis and hemangioma. So this is a multi-system disorder with severe acute impairment of the liver, occurs with hepatocellular necrosis in patient with underlying chronic liver disease. This is the definition for acute liver failure. Okay, so this identity you have to put in mind regarding the pediatric liver transplant. Okay, next one, please. And this is the selection criteria. We will have the King's College criteria. This is the normal. All of you, us maybe know this one, but the this is the King's criteria, you know it all, but also there's some Japanese criteria or Japanese protocol for dealing with these cases, and this Japanese protocol depends on these 6 parameters: the onset of and the course of the disease, how much is it, and they give a score for this patient, and this score, if it's more than 5 or equal 5, this is a poor prognosis for this patient, and they have to go to transplantation very rapidly. Okay, and they have to do a liver ultrasound daily in the ICU to ensure the liver atrophy is found or not. So you have a score from this 6 points. You have, if the score is more than 5, you can go for transplantation urgently. Okay, because this is poor prognosis for this patient. Next, please. Okay, one also of the unique diseases in the children is the hepatoblastoma. Okay, and maybe I'll maybe say 2 or 3 sentences that will change somehow your vision in hepatoblastoma. So next slide, please. Okay, when to do this LTX in hepatoblastoma, it has some criteria that you have an advanced hepatoblastoma with unresectable tumor after the chemotherapy, okay, or after the hepatectomy, like the salvage transplant, or liver failure after the chemotherapy or after the hepatectomy. So if in the unresectable tumor, not amenable for resection, so you can go for transplantation. So in hepatoblastoma patient, you have to, from the day one, you have to make your contact with the oncology, the medical oncology or the pediatric medical oncology team to inform you that this hepatoblastoma patient, we will see the a lot of ways to diagnose, mostly the pretext scoring. This is the one we use mostly for the hepatoblastoma, and we see how. If it is BTX 1 or 2, so you can go for resection, or 3 or 4, you can go to chemotherapy and then transplantation. So you have to know this patient before the operation, before before is to put a plan for this patient together with the medical oncologist. Okay, the contraindication, as you see here, this is what I was saying now, that the incomplete tumor resection after partial hepatectomy or intrahepatic relapse, this is a relative contraindication. But nowadays is the macroscopic venous invasions, either portal vein or hepatic vein or vena cava or any lung metastasis, even in lung metastasis is found as a presentation. All of this are now not considered as a contraindication for LTX. So portal vein, hepatic vein, and vena cava, you can go and deal with them. And lung metastasis, you can make a metastectomy before you do the liver transplantation. Okay, so this is the point that may be different in the hepatoblastoma, that advanced hepatoblastoma, also the only way is liver transplant. Advanced even with macrovascular macroscopic venous invasion, you can go for liver transplant. Even if you have a pulmonary disease, a pulmonary metastasis, you can go for also for liver transplant. Okay, so this is very important, but just to mention. Next slide, please. And this is algorithm used by the Japanese people there in the center. I was also proposed by them to deal with the advanced hepatoblastoma patient. That any patient with advanced hepatoblastoma, you can go for neoadjuvant chemotherapy at first, and then if some regression happens after, you can assess by the post-text after the treatment. If it is 2 or 3, so you can go for, and you have a sufficient residual volume, and the main vascular invasion is not there, so you can go for liver resection. But if you have insufficient volume or have a main vascular invasion, so you have to go for liver transplantation. So I find here that most of the patients with hepatoblastoma that took chemotherapy, most of them will need a liver transplant. Okay, after they took this chemotherapy, and then after the transplantation, they can continue their chemotherapy again. Okay, please next slide. Next, please. Okay, this is maybe somehow also unique for the children. It's called hepatocyte transplantation. Maybe I'm lucky to attend 2 cases in Japan for hepatocyte transplant. And this was the initiation for their program there. Please, next slide, and explain more and more. Okay. What is called hepatocyte transplant? What is the issue? Hepatocyte transplantation is used as a bridging therapy to organ transplantation, to liver transplant. Just in the babies with very low birth weight, below than 6 kilogram or 5 kilogram, you can have a patient, a baby was born maybe a few days, he has 15 days or have 10 days or something, and he presented with acute liver failure, or can he presented with some presentation with end-stage liver disease. So at that time, you can go for hepatocyte transplantation. This is as a bridging for the liver transplantation. So why we do this? Because in the small babies below than 6 kilogram, the risks in the liver transplantation is very, very high in this patient regarding the operation itself, regarding the graft volume, after if you do reduction on these things, regarding the infections, possibility of infections, because this patient will not take any vaccination at that time because he's very small. So try to avoid transplantation in this area, and then you make this bridging hepatocyte transplantation, and then you go for transplantation maybe in 5 or 6 months after human hepatocyte transplant. We do so. Go for next slide, please. Maybe next slide is more emphasizing. This is the what's called the human hepatocyte transplantation. You make a small laparotomy, and you go through, cannulate the umbilical vein, and in this umbilical vein you have to inject the amount that you need for this child, depend on the weight. It is calculated upon his weight, that there is some there's accepted dose of the stem cell that you can give to this child, and you can give it maybe over 1 or 2 sessions or more sessions, and this is the point. And you can wait for the bridging for the 5 or 6 months, and then you go for liver transplantation. I already, as I told you, I was lucky. I have attended 2 cases like this there. Okay, next please. Just some slides from the previous presentation to remind you that this is my team in Japan, and we work. I work here for 1 year. Then nowadays they have done more than 830 cases of pediatric liver transplantation, and they do 70% of the pediatric liver transplant in Japan, as I told you before. Okay, next. The conclusion with my mentor, golden advice, is that you have to stay humble and pick up your motivated young team and exert all your efforts to build your team. Okay, next, please. This is the just to mention. This is the site of the hospital, the NCCG in Japan, and this is the ID and password. You can go and access there some videos for the pediatric administration and some lectures for the pediatric administration done by Professor Katara himself. Okay, and this site, so you can just keep the site with you. Next, please. This also the dream will come true. I think I am fully trust with Professor Kilo to go, that he can go there. Okay, next, please. And also just remind you that we have to stay united for Africa, as Africa deserves the best. This is the oldest one, but I will put maybe in all my presentations in Africa, just to remind you that we have to be united as much as we can. Next, please. Thank you very much for this presentation. Waiting for questions.
Thank you so much, Dr. Sami, for that presentation and for bringing to light so many issues in the pediatric population. Interestingly, for adults, we worry about small for size, and in pediatrics, we worry about big for size. So it's a total opposite of the spectrum. At this juncture, we shall welcome questions to both presentations so that we can wind up this session and go to the next session.